So a few comments just to preface this presentation. The first is that I did not feel that you should be deprived of the wisdom of Christian, which has been a guiding light for me in the 30 years of my career. The second is that in 1988, I suppose I was his fellow when he was introduced to me as the chief resident at the Inselspital Hospital in Bern. And in 1993, he introduced me to Givenchy, two events that changed the course of my career, and you all younger orthopedic surgeons may be inspired perhaps by how important these kinds of relationships can be. And Christian wanted me to share with you that while one can pass on knowledge, it's inspiration that lasts and makes a difference. The other thing I wanted to say is that the work that I will present here ultimately culminated in him winning the Kappa Delta Award for bench to bedside in management of rotator cuff tears. And the unique thing about Christian Gerber that has defined him in my way of thinking as the most important scientific thinker of his generation is he always starts with the question why, and then how and what come after that. And so be my judge when you hear my attempt to present his ideas here. So of course I have no conflict, and this is his. So how do we think about the rotator cuff? Well, we think of four muscles from the scapula to tendons that insert into proximal humerus and affect overall shoulder function. And the tendons unite with bone in what he describes as more of a contact glue than an interwoven network, and this is an essential structural geometry which we somehow try to reproduce when we repair the tendon. And things happen at a histological and biomechanical level, and these are the insights for these things. So Gutaye showed in 1994, actually with CT scan, what happens with muscles, and that force can only be transferred to tendons attached to the humerus if attached to a functioning muscle. And so this is a muscle tendon disease, not just a tendon disease. And actually, the work potential of shoulder muscles is expressed as a consequence of their excursion in their cross-sectional area. And it's not by accident that the good Lord created a balance between the subscapularis and the posterior muscles, inclusive of the supra, infra, and teres minor, in terms of their work capacity for a balanced anterior-posterior force couple. And of course, these have been highlighted by people like Steve Burkhardt, who gave us insights relevant to how we treat these problems arthroscopically. So modeling the rotator cuff and shoulder function is very complex, and we've made some progress, really because of people like Christian. So, as only he can express with his dry sense of humor, the rotator cuff can be modeled as a hood. And the four muscles simply move the humeral head the way they move his head here. And he's actually making a joke now, and you can see how dry his sense of humor is because his mouth is not curving upward. Now, this can be used to represent what happens with actual tears. Meyer showed that the subscapularis tendon can lengthen, and this can be the diagnostic feature of subscap tears, and so structural compromise of the muscle tendon unit may occur in partial tears, and these can be associated with dynamic lengthening and loss of force transmission in the rotator cuff, even without a major structural disruption. So this is an important insight because it gives further credence to the concept that this is a muscle tendon injury. And if you look at ultrasound here, functional failure and continuity can occur with elongation of the tendon, affecting dynamic appearance on ultrasound, as shown here in a study that he did, looking at otherwise a healthy tendon and a tendon with a partial tear, and the fact that one is contracting and one is not so much contracting and is really functionally not working. So tendon tears which enlarge may cause weakness not just from loss of load transfer, but also from pain, which may be a form of power inhibition. And so someone who seems weak may be weak because of pain as well as structural loss. And this is an important concept if you examine your patients. And let's consider that for a moment. Let's consider what we as clinicians determine of our patients. And let's look a little bit about differential in diagnosing these. Well, Christian spent a lot of time defining AC joint pain, and clinical examination has to rule out common causes of pain, and this is a common cause. So it turns out that palpation is highly sensitive and cost-effective. And you're tender at the AC joint for a real reason. And the pattern of pain, and this was a wonderful study he did where he volunteered all of his residents to participate in injection of sterile hypertonic saline into the AC joint, published in 1998. And the resident who did this study told me his greatest pleasure was to do this injection to Christian because it was so painful And the pattern of pain represented here demonstrated that AC joint refers widely, different parts of the shoulder, but generally always up into the trapezius area. Very important observation, because subacromial pain is typically referred to the middle deltoid in the arm, but never proximal to the AC joint. An important observation in differentiating between the two. So think about pain pattern when your patient complains. Rule out stiffness is very important. Impingement test is more accurate if stiffness is ruled out and patients present with blends of conditions, but beware of the middle-aged woman with a atraumatic onset of pain who may be presenting as a prodrome to frozen shoulder. Impingement tests can be very helpful if they're flexible because you will see an immediate response. And this is sensitive, however, not a specific test. And then test the function of individual muscle tendon units. One can predict which tendons are torn, and this is very important. And not just Christian, but Gilles Walsh have pointed this out very accurately. So small tears may be very well tolerated because, as Burkhardt showed us, when you have an intact cable, the force transmission is preserved through the remaining muscles. And it's important to understand how people with small tears can actually be relatively asymptomatic, one of the dilemmas that we have. However, when you have a large tear and multiple tendons are pulling, you can see here you can propagate the tendon tear. And this is a different concept about whether you should fix the rotator cuff earlier or later because of the potential for decompensation of function and progressive fatty involution, which we'll talk about in a moment. So let's consider the exam, and this is from him, his video, very insightful video. So if you examine the patient, the shirt should be off, and you need to look at passive motion, and you need to differentiate passive from active motion. And not infrequently, I will see patients where this is not done, and it's very difficult to know for sure whether or not the patient is stiff and also weak. So here's passive external rotation with the arm at the side, and you can also determine if the patient has pain here, which will give insight into their problem. This particular patient maybe this may also be a manifestation of a frozen shoulder. You can look at passive abduction while stabilizing the scapula and comparing it to the other side. And in this particular patient, she has relatively good passive abduction but pain, which would be consistent with a subacromial process. And I think it's important to be aware of that. Here she has limited motion actually, and she has pain with abduction, so maybe that's actually frozen shoulder. So if we look at the different muscles, we would test the teres minor with the arm in abduction and look at strength of external rotation. And clearly you can see here a difference from side to side. I learned from Christian to measure this with quantitative way, and I use a measurement tool that actually gives me force. Here's the classic external rotation lag sign in abduction, which I believe Gilles Walsh described as the hornblower sign. And you can correlate this with fatty atrophy and a tear of the posterior rotator cuff. And this is a very bad prognostic finding, but pathognomonic for an irreparable rotator cuff tear. Then clinically you can know this before you obtain the MRI. And then as we work through the other muscles of the rotator cuff, we look at the infraspinatus with the arm at the side. And if we look at passive external rotation and then lag signs and strength with the arm at the side, we express the infraspinatus functioning. These are very important steps that you can do to give you insight into the problem the patient has, which will also guide you in your decision-making of what is realistic for a surgical solution. This particular patient is simply weak in external rotation. However, this patient here, you see, she can maintain her external rotation on the one side, but on the other side she has a significant external rotation lag sign with the arm at the side, pathognomonic for infraspinatus dysfunction, clearly shown here with isolated fatty atrophy of the infraspinatus, and may or may not be with an infraspinatus tendon tear. And then finally the supraspinatus, which contributes 16% to the overall abduction moment with the arm at the side. If we look at abduction strength, very important point, because this is extremely specific to infraspinatus if they're very weak in abduction and if they have good strength on the other side, and a very useful test here to isolate the supraspinatus. And again, you can see here some atrophy of the supraspinatus and an obvious supraspinatus tendon tear. Now, one of his greatest contributions was the subscapularis. He has not much to say about the biceps, so this is all he's showing you here. But with the subscapularis, in 1990, he described isolated subscapularis tears and the concept of passive increase of external rotation and also the liftoff sign, which many have advanced testing for, but this is a classic liftoff sign. And actually, when I was a fellow with Russ Warren, after I was with Christian Gerber, I remember well a patient that had this, and Russ had to put the scope in to determine that the subscapularis was torn, but I was able to determine the liftoff sign in the holding area and knew before he did that just because of my experience with Christian. Again, you can see here the difference in the liftoff sign, and this, we have other tests for this now, the belly press sign and the bear hug sign, and etc. Here you see the so-called belly press sign and pathognomonic for subscap tear if the arm goes into internal rotation and the wrist flexes. And here you can see an obvious subscapularis tear with fatty atrophy in this patient. What's also interesting is the so-called anterior superior rotator cuff tear, and I learned this from Christian Gerber, and when Larry Higgins and I wrote about this and submitted to JBJS, they said there's no such thing as a separate entity of anterior superior rotator cuff tear. A cuff tear is a cuff tear. But you can see how the humeral head moves in an anterior superior direction, what's called escape, and this is a very important concept. Now, why is this all important? Well, if one looks at the burden of musculoskeletal disease, the shoulder was the second most common anatomic site, 22% for sprains and strains treated by primary care physicians in their offices. And frankly, in sick leaves per case for occupational illness in private industry, it was number 2 after abdominal problems. So why do rotator cuff tendon tears fail in the first place if we're making this exam? Well, trauma is certainly a cause of failure of normal tendons rarely fail. An intrinsic degenerative process has been identified since Kodsman's observations 100 years ago. So let's examine that. Well, is there a genetic predisposition? Is it biological, mechanical, or both? And we have documentation that full-thickness rotator cuff tears is a risk factor in siblings, 2.4 times. And if it's symptomatic, it's 4.65 times. So there is a familial predisposition, but what is that? We also know that extrinsic factors such as smoking can increase the risk of tearing twofold, and that smoking interferes with healing. This is also an important factor when we look at our patients. So extrinsic attrition from acromial contact was what Neer told us was the mechanism for this. And he stated that 95% of all rotator cuff tears are caused by subacromial impingement, which is why acromioplasty was such a controversial concept, particularly when we moved to arthroscopy. Now, Schneeberger showed that experimental subacromial impingement in animals caused only bursal side tears, did not cause articular sided tears. And frankly, anterior acromioplasty did not prevent progression of full-thickness rotator cuff tears, which led to the conclusion of many that impingement is a consequence and not a cause of rotator cuff disease. And I'm sorry for Dr. Neer, who was a brilliant thinker, but his concept was not entirely accurate. And so what about the concept of microtrauma with overhead activity? Is there a chronic repetitive overload? Well, let's look at Roger Federer, who is Christian Gerber's hero, I would say, and probably one of the most famous, if not the most famous, Swiss athlete. Why does he not have a rotator cuff tear? And why are supraspinatus tears as frequent in the dominant as in the non-dominant limb? And why are supraspinatus tears more frequent in manual than in office workers? Why are they not, actually? And why do we have either rotator cuff tear or osteoarthritis? It's rare that we have both, typically. So this led him to ask that question, why, I told you. And he started by looking at the upward tilt of the glenoid and found that superior inclination of the glenoid was directly correlated to risk of rotator cuff tear. And that made some sense when you look from a biomechanical point of view. And then Niefler, one of his colleagues, looked at lateral extension of the acromion and defined the acromion index and the fact that it was higher with a longer lateral acromion in people who had rotator cuff tears. And in fact, the acromion index was directly correlated to rotator cuff tear and OA, because a shorter acromion was associated with OA and a longer acromion with rotator cuff tear, and I'll show you in a moment why. So when you have a long lateral acromion, you increase the deltoid force, which creates an imbalance and a greater shear in the supraspinatus, whereas a shorter acromion will actually make the deltoid agonistic and increase joint compression and promote osteoarthritis. And the combination of glenoid tilt and acromion length is what he subsequently defined as critical shoulder angle, which has been something of a debated concept, but one which he has clearly shown by careful reflection is quite important. In fact, if one has a critical shoulder angle greater than 35 degrees, there's an 86% probability of rotator cuff tear, and if it's less than 30, There's a 92% probability of OA. But most of you may not believe that, but you probably don't look at it. So in the laboratory, as only he can do, he always goes from bedside to bench and back. He created a simulator setup, a biomechanical study that modeled this. And what he found was that the joint reactive force and shear component was greatly increased with a larger critical shoulder angle in lower degrees of abduction, like when you use the mouse at the computer rather than when you work overhead. And this may be what's happening with the supraspinatus. And in fact, the supraspinatus must work at 4 times greater force if the critical shoulder angle is greater than 38 degrees. So it makes sense that it may fail because of its overload, and therein lies perhaps a component of the familial predisposition that we may be seeing in some patients. So the next question is, can we change the anatomy of the patient in a way that protects them? And so he's investigated, is it possible to shorten the acromion, and does that make a difference? And should we do that in our patients? And he published that yes, it is possible and it is safe, and this is a before and an after, and theoretically this should reduce the strain into supraspinatus. And in fact, in an article recently submitted, he showed that if a cuff healed, the post-op critical shoulder angle was less than 33 degrees, with significantly greater abduction strength, compared to the post-op critical shoulder angle being larger, had a much higher incidence of failure of healing. Think about that for a minute. How many of us really even consider that? And where will we be in 5 years from now, when this article is published? Will we all be shortening the acromion? Well, what about failure rate? It's been reported there's a very high failure rate. And what about the lessons and insights he's given us in this? Well, one thing that he looked at early in his career was the strength of fixation versus the contractile force of the rotator cuff. And it is always the case that the muscle force wins over the repair strength. Even though we have optimized repair strength with a lot of data that I'll show in a moment, nonetheless, this is the rationale for an abduction pillow, at least his concept. So this was classic work that he did, looking at suture and tendon and their impact. And some sutures elongate and some break, and we now all know that we want to use sutures that are resistant to stretching, and so the birth of all the different varieties of unbreakable sutures that we now use, because we want to avoid gapping in cyclical loading. But it is also important to understand the suture configuration is relevant, and his concept of the Mason-Allen suture grasping technique came from this, and many of the concepts that have been put forth by people like Burkhardt with ripstop, and Burkhardt and Snyder with ripstop, and with all sorts of other approaches, consider these things built on the concepts of Gerber's initial investigations. And then fixation to bone. Bone is a weak factor. Wolff's law, with chronic tears, the bone becomes poor quality. And so the configuration through the bone is important. The position through the bone is important. Augmentation is important. Suture anchors may be better in certain circumstances placed into better bone. Insights we never had before 1994. And then I think the best position of the tendon stitch. And Steve Burkhardt pointed out about the concept of the cable and the crescent. And so you can see here that medial to the cable is stronger. Again, the basis for what we do arthroscopically now. And then also the concept of how we make knots, and we've had, of course, knotless sutures now and such, but these also very important. Now, we still do not understand why fatty infiltration of muscles occurs, except that we know that it's related to muscle tendon retraction, and it's generally irreversible. And in studies that he's done, what he has shown, and others have subsequently shown, is that with fatty atrophy, the major limiting factor of repair is the stiffness which develops in the muscle. And a muscle which is stiff cannot generate a force. So ask yourself if it makes sense to repair a short and stiff muscle with a tendon extension. And is that really going to generate force? So Christian wanted to leave with this concept. You will not pass someone by walking in their footsteps, which is to say, the greatest thing you can do as a student is to find someone worth imitating, but then find a way to walk past their footsteps, which is the way he thinks. And I've been lucky enough to try to walk in his footsteps as much as I can, and to some degree trying my own footsteps, but oftentimes the snow is much deeper where I'm walking. He wanted me to share with you that he first came here in 1977, and he's very sad not to be here, and he wishes us all well and hopes that some of what I presented to you today may be something that inspires you to think about tomorrow. Thank you.